Hi everyone, Jennifer Blevins-Smith with Integral Clinic Solutions, and you're watching my YouTube channel, Navigating the Business of Medicine. Today I want to just talk about the basics of locum tenens. Understanding locum tenens and how to bill correctly is going to be super beneficial in your practice to prevent denials, stay compliant with guidelines, and also protect your revenue when using temporary providers and hopefully not having any takebacks if things are paid initially. Let's start off with what is locum tenens? Well, it's a temporary provider filling in for an enrolled and contracted provider in the practice. There are certain situations where a temporary provider or doctor, it's usually doctor to doctor. Sometimes there are some situations where a physical therapist can be in locum tenens, but you would need to do research on that. But it's basically if a doctor is out of a practice for a temporary amount of time, you can hire another doctor who is not contracted under your group to fill in and see patients. Some of the examples for temporary absence could be vacation, they're on a leave for a certain reason, like a medical leave. Maybe they had to go take care of a family member who's sick. Maybe they're on maternity leave, or there's some kind of vacancy in your practice where you're trying to hire another doctor. And there are some exceptions, like if a doctor is active duty military and going to be gone, there's some exceptions there for longer periods of locum tenens. So if that's something that might affect you, you would need to look into that. However, you have to make sure that you're distinguishing between a locum tenens and some other situations where a doctor might be filling in. The most common is locum tenens, especially because of vacations and smaller practices where losing the patient volume during that vacation time could be financially detrimental to the business. CMS has some very clear guidelines with locum tenens. Please note that not all other insurances actually follow CMS guidelines for locum tenens. Many of them do. However, like everything else in healthcare, you would need to check with all of your payers and contracts to find out what the locum tenens advisement and rules are for each payer before you jump into this. But we're going to just basically talk about the CMS guidelines today. So the locum tenens is billing, and it's only allowed for Medicare Part B services. So there's no facility-based billing. So if you're in a hospital or something like that, you would not be able to use locum tenens. Just be aware of that. It's very similar to the Incident to billing guidelines in that regard. You have to have a provider, doctor filling in for an absent provider, but that absent provider who normally is working in the practice needs to be fully enrolled with Medicare. Okay, that's very important. But the locums doctor does not need to be enrolled in Medicare. Okay, so the doctor that works full-time needs to be credentialed, enrolled, contracted with Medicare. The one covering temporarily does not. A lot of the insurances will have something similar where they'll say they need to be credentialed, but they don't need to be contracted, or they don't need to be credentialed or contracted. It just depends on the insurance. So you have to find that out. And then the rule that they follow is the substitution physician rule. So because locum tenens has a certain limited amount of days, it's 60 a calendar year. So it can be up to 60 continuous days, but it can restart the 60-day period when the original provider returns. On the claims, you have to add a modifier Q6 on them. It's very clear. That's how you're indicating that there is a locum tenens provider, doctor covering and seeing the patient that's being billed out for services. That means that the claim has the absent doctor's information on the claim. So box 24J, the rendering provider, is still the provider who is gone that's usually working. You never put the temporary provider's name on anything on a claim, but you indicate locum tenens is being used in the practice by putting that Q6 modifier on those claims. And then you have to make sure internally at your practice that you have documentation that shows the records of the locum services, the dates, how they're being compensated. All of the details needs to be in a log that is kept in the practice. So if Medicare or the insurance were to have any questions about locums, they will come to you and you can provide that information. So billing locum tenens to Medicare specifically, just quick overview of step-by-steps. You're going to bill under the normal rendering providers MPI in that box 24J like I talked about, so that doctor that's absence information will be on there. You're going to add a modifier Q6 to each service line on the claim. The place of service rules remain the same. There's no reassignment or enrollment needed for the locum's doctor. And they're very specific on how this locum doctor can be compensated for their time. They have to either have a flat per diem rate or a fixed hourly rate. Okay? It cannot be tied to the volume or collections of what's brought in for the patients that they're covering and seeing, okay? So nothing in their contract, agreement, compensation can be directly related to the patient volume or the payments from the insurance companies and patients. It has to either be a flat rate for the time that they're covering or an hourly based rate, okay? And it has to be clearly documented in all that other information we just talked about. Commercial payers, again, you have to check with them because unlike Medicare, commercial payers and plans do not share a universal rule like Medicare does. And some of the key questions you would want to ask them are, do they follow Medicare's locum rules, which we kind of touched on? Do they require the locum to be credentialed with their insurance? Remember, there's a difference between credentialing and contracting, and I have other videos that go over this. So if you're not sure, check those out. But do they at least have to be credentialed and recognized and approved as a good provider on their network? And do they require billing under the locum NPI? Like the MPI of the doctor covering, because CMS doesn't, right? You put the absent doctor's MPI in there. But does the commercial payer require that? Do they want modifier Q6 on the claims like Medicare does? If they follow Medicare guidelines, then you have the answer. But if they don't, you need to ask. And do they allow for reciprocal billing for temporary coverage? Okay. So many commercial payers, just so you know, require full credentialing, which makes sense, right? They want to make sure they've at least vetted that individual, or they have some kind of temporary or expedited privileges, the covering doctor does, or a provider roster is updated at the group and they include the locum doctor on that. So it's really important. If you don't have this figured out, it could lead to denied claims. It could lead to money being taken back down the road if they audit something and find something fishy or odd and they come back to you and decide that you didn't follow the proper guidelines. They will ask for their money back for anything that was recently paid, okay? Some of the documentation requirements I just want to go over, we briefly touched on that, but you have to maintain a locum coverage file. And in that file, you need to have the contract or the agreement with the staffing agency or the independent provider. If you know, like a colleague or someone's covering for a doctor in your practice, you have to have a copy of the contract or the agreement that they sign with all of the details. You have to have the specific dates of coverage and the reason that they're covering, maternity leave, vacation, things like that. You have to have notes on payer-specific instructions. So you have to look at all your payers that you're contracted in billing, and you need to have notes of your research on that. And you have to have internal communication approvals, whatever that might mean for your actual SOPs. You have to make sure that these doctors are signing notes correctly in their documentation of seeing patients. And the locum actually is going to sign their own name on these notes, right? They're not going to sign the other doctor that they're covering for, because that's almost like fraudulently saying that doctor was there and saw the patient. So the locum doctor needs to sign those notes, and you need to make sure that's being done. And then you have to make sure that billing is still being tied to the regular provider's NPI for CMS and any other payers that require it, okay? Just some common locum mistakes I just want to point out is exceeding that 60-day maximum limit. You have to be careful at monitoring the amount of days. Forgetting to put that Q6 modifier on those claims, that's a big deal. You have to make sure those are on there. Billing under the locum's NPI when the absent doctor's NPI should be on the claim. And again, this is per payer guidelines. Billing under the absent provider when the payer requires the locum credentialing. So if the locum needs to be credentialed and you continue to bill out incorrectly, that is a big no-no. Paying your locum's provider based on collections, which we talked about, is a no-no. Not documenting their start and stop dates for coverage, and letting coverage roll into a new year without any kind of rule review. Okay, just some basic mistakes. I'm sure there's others, but those are kind of the high-hitting ones that you need to be aware of. So you want to make sure you're staying compliant. Check with your insurances before you have a locum start. Have all your ducks in a row. Have the proper documentation. Have files. Have signatures. Know what you're doing. Recheck payer guidelines every time before you do a locums situation in your practice, okay? It's really important to stay on top of this and understand it so that you don't have any negative financial outcomes. If you have any questions or comments about this, please leave that in the comments below. Smash the thumbs up button if today's video was helpful. Subscribe to my channel if you have not already, and please share this with your colleagues whom you feel would benefit from the information. I appreciate the support, and be well. Bye-bye.